I'm Selma Schimmel, talking to you from the 35th ESMO Congress, European Society for Medical Oncology in Milan, Italy. Discussions continue with doctors all over the world. I'm excited to talk to you because at the recent ASCO meeting, the American Society of Clinical Oncology meeting, one of the big areas of discussion was on behalf of non-small cell lung cancer, and in particular the ALK data. And we're here now some months later at ESMO, and there seems to be some updated information. So this is going to go great to further inform patients as to the status and ongoing results for these very important studies.
Yeah, ALK was one of the big news stories at ASCO this year. ALK is a genetic change that happens in about 5% of non-small cell lung cancer. That in itself isn't interesting. What is interesting is that if you pair a molecular test that finds that 5% of individuals with a specific drug that's an ALK inhibitor, you get fantastic results. And what we're presenting here is an update to that story.
How do you determine the unique genetic components of one individual cancer, in this case ALK, so you can then correlate it and find the correct therapy that responds to that genetic, nuance of that cancer?
So there's an ALK test which is conducted on the tumor. So it's not conducted on the patient, it's conducted on the biopsy of the tumor. Sometimes only just on a few slides are required. And at the moment the gold standard is something called a FISH test, which stands for fluorescent in situ hybridization. And what happens when the ALK gene is turned on is it's fused to another gene. And what you see is two red and green dots, which are normally sitting next to each other, suddenly separate, or one of them disappears, as the chromosomes literally rearrange to create that fusion gene.
When you look at the history of cancer, in this case, obviously, we're talking about lung cancer, years ago, a patient got diagnosed and maybe there was an appropriate chemotherapy. Now, as we begin to understand the biology of cancer and, the genomics of cancer, it's absolutely changing the face of how we treat the disease.
I mean, this is one of the most fascinating and I think exciting things that has happened. Because we all knew it was possible, the idea of personalized medicine, to take 100 people who all appear to have the same cancer and then say, well, they're not all the same, and one size won't always fit all in terms of treatment. When you do these kind of tests, you can break non-small cell lung cancer down into ALK gene rearranged lung cancer, EGFR mutant lung cancer, and a whole series of other abnormalities, and then try and get the right treatment to the right patient as soon as possible.
So talk to us about the differences in the research so far and recap briefly what happened at ASCO so we can put it into context to what's happening here.
So at ASCO, just over 80 patients were presented, and there we saw that this drug was producing dramatic responses in about 2/3 of those patients, and some evidence of clinical benefit in about 90% of those patients. And we saw that on average it was taking about 9 months before the first signs of progression were occurring. Now we're presenting data on over 100 patients, 105 patients. And the exciting thing is those results are consistent. We're seeing the same progression-free survival time, 9.2 months. And we're seeing the response rate is a consistent 60 to 65%. And the exciting thing is it's the same regardless of age, gender, number of lines of therapy. If you get the right drug to the right patient, it doesn't matter what's happened before. Even if you're a low performance status, even if you're not a terribly fit patient, you can rise up if you're given the right drug.
Take us through what is going to happen to the standard of care as this data is coming out. How does this translate? This is still a clinical trial.
So the drug is currently only available in clinical trials, but the initial results are so exciting that we know that Pfizer will be approaching the Food and Drug Administration for conditional approval in the first part of next year. If they're successful, then one would hope that this will become a new standard of care for ALK-positive lung cancer.
So this would be called a fast-tracking process?
It would be what's called accelerated approval is what they're seeking.
The the scope of the number of patients enrolled in the trial?
So there are several trials going on. Within the phase 1 study, which is where this all started and what we're presenting data on here, there's just over 100 patients. But there are ongoing phase 3 studies which are randomized compared to chemotherapy. And in total, there's probably about 250 patients in the world so far who are treated. But we expect in the United States alone, 10,000 patients every year would actually fit this category. So there are many people who are ALK positive who don't know it yet.
Over what period of time have the ALK trials been happening?
Well, the phase 1 study started in 2006, but ALK was only discovered in lung cancer in 2007, and so it was a perfect storm of a drug being available and a genetic abnormality found in a common cancer at the same time. And we amended the phase 1 study to allow these patients to be enrolled.
How did you discover ALK?
So ALK was discovered by a Japanese group who took a very insightful approach. They recognized that there were some known molecular drivers of lung cancer, EGFR mutations and KRAS mutations, and they said, well, we're not interested in those. They're a different disease. So they selected a patient who they knew didn't have an EGFR mutation and didn't have a KRAS mutation. And
Could they coexist, all of these mutations?
Usually there is one dominant molecular driver. So there's room for one person sitting in the driving seat of the cancer. So when you exclude those, you're really separating it out into distinct diseases. And what the Japanese group was, they took somebody who wasn't one of these known types of lung cancer, took the DNA out and broke it into little pieces and put it into cells and saw which bit of DNA turned them into cancer cells. And that's how they found this fusion gene. It's very elegant work.
Is it a repair of the DNA?
No, it's the chromosome literally breaks and flips around, and the two ends join together again with the ALK gene fused to another gene which now drives it and keeps it stuck in the on position all the time.
What happens from this point? Obviously, it's going to hopefully go through this accelerated approval process, but help paint the landscape for a non-small cell lung cancer patient viewing this, who may very well have this ALK mutation. What can they expect?
So the single most important thing is that if you're diagnosed with non-small cell lung cancer, is to get tested. There's no getting around that. The frequency of ALK gene rearrangements may vary according to certain clinical features.
And it is called a mutation?
No, technically it's called a gene rearrangement or a fusion gene.
So I have to correct what I said a moment ago. So this rearrangement, even if you are not in a clinical trial, can you still get tested?
Yes. So there is a formal diagnostic test which is tied up with entry into the clinical trials, but there are a number of private providers who will screen for these changes. So you don't need to go to a center. They would like you to go to a center to get the official test done, because if you're positive on that, you're potentially eligible for the trial. If you test with one of these other tests, you still have to be retested by the test specifically used in the trial, but obviously your chances of being positive will be much higher if you've tested positive with something else.
And the testing, you said, is on the tissue itself?
It's on the actual tumor biopsy, because the change is in the tumor, it's not in the person.
Right.
It's the tumor that's gone wrong.
So any patient who is diagnosed with non-small cell lung cancer, if the doctor has not offered them to be tested, is it reasonable for the patient to say, I'd like to be tested?
I would say it was more than reasonable. I would say it was essential. The only way we can find these 10,000 people every year is if we test everybody. There are certain groups, as I said, where it's more likely to be positive, but unless you can identify a group where there is zero chance of it being positive, I believe you should test everybody.
Is the trial still open?
The phase 3 trials are still open, and actually the phase 1 trial will also remain open as a safety net, because if you're ALK positive, I think the goal is to try and get you access to this drug one way or another, and there are many trials that allow that process to happen.
And what about side effects?
The side effects, I think that's what's so exciting. There are no free lunches, so there are some side effects, but they're very mild, certainly compared to chemotherapy, even compared to some of the other targeted agents. There's a little bit of diarrhea or constipation, which seems to settle with time. There is some a slightly unusual visual side effect. At the edges of your vision, particularly when it's dark, you'll see smearing of light. It seems to take the brain a little longer to process visual signals at the edges of your vision. And then that goes back to normal within a few weeks of staying on the drug, possibly because the brain just adapts.
Do we know why there'd be that association?
So the normal function of ALK in adult humans is unknown. What we do know is that ALK is involved in the development of the visual system in mice, so maybe it has some residual role in adult humans. We also know it's involved in the development of the gut in fruit flies, and maybe that's why we get some diarrhea or constipation. It may have some low-level maintenance role that we interfere with in adults.
Are there supportive care drugs available to help patients cope with any of these toxicities? They don't sound minor, but these side effects?
There are. So the major ones is if you have diarrhea, you take stuff to stop you having diarrhea, and if you have constipation, you take stuff to get things moving again. But in general, most people find the side effects incredibly tolerable. The visual thing most people find rather funny. I warn people about it first so that they don't freak out, but they usually end up giggling when it happens.
Well, okay, and I meant to say they don't seem major, but nonetheless, you know, of some issue to patients. And what about skin reactions?
None. I mean, the only cumulative side effects, so most of those side effects I've described actually get better with time. The only cumulative side effect that we know about is some mild swelling of the ankles. And it really is mild. It's the sort of thing that you feel rather than other people can see.
Will there be now subsequent data following the ESMO meeting that may be released in the near future?
I think one of the things that we're most excited about that we presented here is the data that people who progress whilst on the drug, if that side of progression is treated, for example, with radiotherapy, in the study they were allowed to continue on the Crizotinib. And here we've shown that sometimes the duration of clinical benefit after that initial progression can be months and in at least one case years, because the drug is still controlling most of the disease. And that opens up a whole new area of research, and I think we'll see a lot more data coming out.
And what is the scope of time a patient can stay on the drug?
Well, they can stay on it as long as they're deriving clinical benefit. So that 9.2 months is up to the first point of progression. But if I give you an example from what we presented today, one of the first patients who progressed after just over 40 days on the drug. And they had a single deposit in the brain, and that was treated. They have continued to stay on the drug for over 460 days since then, and are still on the drug, because the rest of the disease outside of their brain is perfectly controlled.
And combination therapy in regards to integrating standard chemotherapy?
Well, I don't know that we need to rush straight to integrating with standard chemotherapy. I think one of the things that we don't know is in these sites of disease where they progress, where they become resistant, we don't yet know the mechanism. Some patients are now being re-biopsied, and we're starting to molecularly interrogate those biopsies to try and find it out. So when we understand why the cancer becomes resistant, those combination therapies in the future can be much more rational.
It's just so striking to me how far we've come. If you took a medical oncologist from 25 years ago and sat him down in this chair with you, his or her comprehension of cancer from that era to where we are today would be two different worlds.
I think if you took a medical oncologist from 3 years ago and sat him in this chair, they'd still be surprised. The speed of change is phenomenal.
Thank you very much for sharing this information. I was hoping that we could get an ALK update, knowing that it pretty much was the big talk at ASCO, to see in a matter of months where we are and looking at perhaps accelerating approval. What a message of hope for our viewers facing lung cancer.
Yes, indeed.
Pleasure talking with you.
Thanks very much.